Hi there, I'm Dr. Paul Houle, and welcome back to How I Do It. This week we will be featuring Dr. Ray Gardocki of the Campbell Clinic. We'll be discussing endoscopic spine surgery. Why bother? So, welcome back, Dr. Gardocki.
Thanks for having me, Paul.
My pleasure. I've heard this talk a couple of times, and each time I hear it, I'm just amazed. The title of your talk is Why Bother? And you're going to go through and talk about why surgeons might want to consider doing something different. I know one of the biggest obstacles that I see in surgeons is that they say, you know what, I've been doing discectomies this way for a long period of time. I get great results. Why should I change what I'm doing? And I have certain opinions. Why don't you tell me what your opinions are?
I mean, it's toughest to change somebody's mind with something that they're happy with. But to think that there might not be something better out there, I think is putting your head in the sand. So, who wouldn't want something that's less invasive, hurts less, faster recovery? Um, some people might think the benefits are marginal, but if you look at long-term results of most spine surgeries, they're similar for different techniques. It's the short term where you have the biggest effect. So the immediate recovery, the ability to avoid narcotics, the ability to avoid general anesthesia, these things are all have immediate effects on the patient and the recovery process. And that's where you have your biggest treatment effect.
One of the analogies that I always make, and tell me if you agree or not, is that, we were trained to do surgery a certain way. And the way that we were trained is the way the people that trained us, that's how they were trained to do it. So we're going back 2 or 3 generations, and really a lot of surgeons are resistant to change, and this is just something a little bit different.
Yeah, I think it might be something that just in my innate nature. The anytime I hear somebody say, "Well, that's the way we've always done it," it turns my stomach a little bit. Like I can't cook a recipe the first time and not change it somehow. So that's
That's right. So,
surgery. We're going to go over just kind of a 10,000-foot view of what literature is out there. And then we're just going to kind of go over a few cases. There's a thought experiment in there in the middle to kind of get you to be introspective. Um, that's basically the layout of the lecture. So,
awesome. I love being introspective.
all right, so this is the universe of knowledge. So no matter what you're talking about or what you're getting into, this is your typical universe, right? So there's the stuff what you know what you know, the stuff that you don't know, and then the stuff that you don't know you don't know. And it seems like when you start off with something, um, this green piece is really big and everything else seems smaller. And the farther you get into it, you know, conceptually you would think, oh, as the green piece gets bigger, everything else gets smaller. But what I've seemed to have noticed, especially with spine surgery, is the larger the area of the green piece is, the smaller the percentage of the total pie it becomes. And I realize there's a lot more I know I don't know, and there's a lot more I don't know I don't know. So, um, spine surgery is a very challenging, stochastic um, process that we never seem to stop learning. So, shedding off your mind to new ideas, I think can really hurt the options you have to offer patients.
I couldn't agree more. I'm sick of being in the yellow.
Yeah. So this is a Gartner hype cycle of new technology. This kind of applies to like cell phones and computers, but this is like the best description of new technology in the spine, right? Uh, you got the technology trigger, the peak of inflated expectations, the trough of disillusionment, the slope of enlightenment, and then the final plateau of productivity where things actually kind of shake out when they're in everybody's hands. So, you can kind of think of any new technology, whether it was pedicle screws, disc replacement, IDET kind of just fell off the trough of disillusionment. But, you know,
Yeah, it just
how
kept
many,
going until it hit and crashed and burned.
right? So, how many new technologies have we seen that follow this? And so, kind of what I want for the people that are out there listening to this to think about what they think, where they think endoscopic surgery is. Is this the technology trigger? Is this a brand new thing? Is this the peak of inflated expectations? Or guys like myself and Paul just off our rocker and promising things that are unreasonable? Is this the trough of disillusionment? Are we just at, is it just going to get better from here on? Are we in the slope of enlightenment? Are we at the plateau of productivity and there's nothing new under the sun that's going to come? So I have my answer. I kind of want you to make your choice beforehand, and we'll see if it's the same choice after the lecture. So this lecture is going to be kind of geared towards a discectomy, because that's where most people are going to start with this, with endoscopic spine surgery. It's the most straightforward way to go with this, and it gives you the most immediate results. So if you kind of go through the history of endoscopic spine surgery, the first generation was actually the transforaminal approach. These were things like the young endoscopic system, percutaneous endoscopic discectomy, and the transforaminal endoscopic lumbar discectomy that we do today. The second generation was really the interlaminar approach, both uniportal and biportal, kind of a more traditional approach. So anatomy is more what people are used to in the second generation, but it came a little bit after the first generation.
So getting back to just starting with discectomy in your first generation with the young endoscopic spine system and the percutaneous discectomy, I think it's important for everyone to get away from utilizing the term percutaneous, because it has some negative connotations as far as the insurance companies are concerned.
Agreed, totally. And really, percutaneous, if you look at the CPT code definitions, percutaneous means image guided. It means that there's no direct light-based visualization. This is a direct light-based visualized procedure. This is no different than using a microscope, loops, endoscope, the naked eye. You see the structures with light. It reflects off the structures. You see the actual structural anatomy, and that's how you do the surgery.
And I think that's the key point in what we're trying to discuss here, is that this is a light base. We're visualizing, we're seeing traversing root, we're seeing exiting root, we're seeing pathology. We're not relying on an x-ray to tell us exactly where we are and what we might be looking at. We're looking at it directly.
That's not to say that you won't get occasional fluoro shot to confirm location, just like you would in an open surgery or placing pedicle screws or any other way you do the surgery with a tube. But it's primarily direct light-based visualization. So, and that takes us to like the third generation, where now we're able to do endoscopic decompressions and foraminotomies. You know, the instruments have gotten better, the drills have gotten better. The Kerrisons, just a few years ago, there wasn't really a functional endoscopic Kerrison. Now there's all sorts of different Kerrisons available. And then what I'm going to call the fourth generation, which is the newer innovations, things like endoscopic interbody fusion, where we can place implants and actually achieve fusions through an endoscope. That's the new frontier.
Exactly. I mean, this is where we take a technique and really turn it into a platform to do other things.
Correct. And I think that's the argument to get started here, so that you can eventually be comfortable with this. So less invasive surgery usually progresses from big to small, whether it's ENT, orthopedics, general surgery. You typically decrease the wound size and hone the approach to the pathology over time. You think about lap gallbladders. I still remember when people had 6 or 8 inch big giant gashes in their upper abdomen to take the gallbladder out. And then I remember when the first guys were doing laparoscopic cholecystectomies and injuring the bile duct like 30% of the time.
I know, I do too. How did we get to become the old guys? What's happened?
It's like I can remember all that stuff now. So the first generation of transforaminal endoscopic surgery is actually a story of small to big. So it's kind of not the typical way you would see things become less invasive. It actually starts in 1973. Parviz Kempman describes a percutaneous nucleotomy using a Craig cannula. So basically took a big needle, inserted it through the foramen, and just cored out the disc and tried to remove the herniation underneath the traversing roots. In 83, Forst and Hausman report the use of a modified arthroscope in the disc. So first chance we have to actually look around inside. Camden and Gelman the same year reported 72% success rate with 136 patients with their percutaneous nucleotomy technique, but they didn't have controls. So, in clinic, I'll tell patients that you have a 70 to 80% chance of success treating this conservatively, because a lot of disc herniations resorb, and the least invasive surgery is still the surgery you don't do. So, whether these were actually successes or just the natural history, we're not really sure because there was no control.
It's funny, back in like 2012 or so when I was doing the spinology implant, I always said, well, why can't I just look inside the disc space and see if I've actually remove the end plate like I thought? And I tried to get the endoscope from the that they use for knee scopes and shoulder scopes, and the orthopedic surgeons wouldn't let me have them. They were afraid I was going to break them, so I never ended up doing it.
Well, I've seen you operate, Paul, and I think there's a chance you would have.
It was probably a good decision.
So 86 and 87, Camden and colleagues introduced a working cannula. So now you've got actually instruments with forceps you can reach around and remove different structures. And then in 88, you see the first published endoscopic view of a herniated disc. So you see the kind of the roots of the first generation have been around for a very long time. This is Camden's triangle. I'm sure everybody knows this. Parviz-Camden described the triangular safe zone in 1990, bordered by the exiting root, traversing root, super end plate of the lower vertebra. This is the key to the transforaminal approach. This allows access to both the lateral recess and the foramen. It's your landing zone. You have to be comfortable accessing this spot to be able to use a transforaminal approach effectively, and that's why we call it Camden's triangle, because this was Parviz-Camden's idea. So in contrast, if you look at the second generation of endoscopic surgery, it kind of follows the more traditional big to small. So if you go back in the late 90s, Ken Foley published a surgical experience treating herniated disc through a 25-degree rod lens endoscope, placed through a 16 millimeter tubular retractor. Basically concomitantly published by Rick Fessler and Larry Koo. The tubular approach subsequently became popular with the use of a microscope for discectomies, decompressions, and fusions. It's something that I've done for well over a decade, and I know you're very facile with the tube as well, Paul. And we still use those for a lot of our cases.
I mean, this is how I started. I remember in residency, we were fortunate enough to have an anatomy lab, and we would go down and use the MED system with the endoscope to learn to do discectomies. The problem was that it would always fog up. You couldn't see anything.
Right.
And that's how we transitioned to using the microscope.
Yeah. So you remember how bad the optics were, how bad the cameras were. The fact that the MED mounted the endoscope to the side of the tube, so you were a distance from your surgical pathology. So it's very difficult to judge depth with a monocular vision when the total depth of field, if you're trying to judge something that's a millimeter or two difference in depth, but you're 2 or 3 centimeters away, that's a very small percentage change. It's very hard to see that. That's one of the things that people who have not used a modern endoscope will criticize and say, oh, you don't have binocular vision. Well, anybody who's ever played a video game has no problem judging the depth with excellent precision between, say, the ligamentum flavum and the dura, even in an adhered situation, because you can look around the corner, you have excellent parallax from the wide angle lens, and really your depth perception is just not an issue. So, when I hear those criticisms, it's just like, okay, yeah, I know you've never actually looked through a scope or played with it. Mm-hmm. But that's why the microscope became popular with the tube, because you took away the visualization issues. You did gain binocular vision, because the average interocular distance of a microscope is about 22 millimeters. Average interocular distance of a surgeon is about 65 millimeters. So you basically can't see with depth perception down a tube if you use a small one. Look with one eye. With the microscope, you get good visualization, great lighting, and you have depth perception. The main criticism is you have a 10,000 foot view. It's like a satellite photo view of everything you're looking at. You can't see around the corner. You can't reach around the corner.
And I think this is sort of the branching point where more neurosurgeons took advantage of the use of the tubular retractor, because we had use of the microscope and use the microscope for most of our other types of surgeries, whereas most orthopedic surgeons don't use microscopes but use endoscopes much more, which is why if you speak with the Chinese or the Koreans, why endoscopic surgery is so much more popular there, and it's mostly done by orthopedic surgeons. It's because they don't have enough microscopes for the neurosurgeons are too busy to do spine surgery. They're doing brain surgery. They're using the microscopes, and it's much more common for the orthopedic surgeons to use the endoscope, and so that's why it's much more popular in China and Asia than it is here in the United States.
Yeah, and I think that's a fair assessment too, because in general, neurosurgeons are more comfortable with the scope. Nowadays, I think it's less of an issue. But even when I was trained to do ACDS with loops, and I thought that was horrible.
And I mean, now I need the microscope to close the skin because I just simply can't see it. Oh Lord.
So you can see we're progressing from that sort of retractor to, say, like the Delta set. That's the Joymax interlaminar set. This is a 13 to 14 millimeter tubular retractor. It's a 10 millimeter scope. It's got a decent sized working channel, so it's got decent kerricins to remove bone for the interlaminar space. But even this tube, in some cases, is a bit on the big side, and it doesn't allow you to be as nimble in the interlaminar window. So it's fine for 4.5 and 5.1, but you get up to like L2-3, where you get a very narrow interlaminar window, very narrow pars, especially with hypertrophic facet. And it's tough to get this to sit down on the bone and create that seal where you're pushing away your soft tissue and not damaging it. You're basically bypassing the soft tissue and going right to the pathology. So we now have even smaller scopes. This is the Alesis Pro set. This is an 8 millimeter cannula, and it allows you to really wander around, and you can do unilateral laminotomies, bilateral decompressions, interlaminar discectomies, lateral recess decompressions, facet cyst resections, and really gives you a lot of freedom to move around. The instruments are a little smaller, so it's a little more cumbersome to do a lot of bony work, but everything's a trade-off. So between the interlaminar approach and the transforaminal approach, you really have access to just about any disc herniation in the thoracic and lumbar spine, and even some in the cervical spine. So the interlaminar approach is primarily for L5-S1 posterolateral herniations. When we're talking about disc herniations, again, the focus of this talk is to talk about disc herniations, because that's where people are going to start. When you become more facile with the scope, you'll start to do decompressions, both unilateral and bilateral, through an 8 millimeter incision. You can use the interlaminar approach at higher levels when there's an adequate interlaminar window. So sometimes at 4.5, there's good space there, and there's room to use the interlaminar approach. You may also use it if you need to do a lateral recess decompression at the same time. So if there's some lateral recess stenosis, the interlaminar approach is a more direct way of getting that. The anatomy is much like a traditional microdisc, but the manual technique is different. So this is one of the things where a lot of the endoscope companies will push you towards a transforaminal approach. I actually think the interlaminar approach might be a good place to start for people, because it's harder to get lost there. You're just so much more comfortable with the anatomy, and all you have to concentrate is getting your hands to work. So that makes it a little bit easier. At least there's only one thing for you to worry about. That being said, the transforaminal approach is an amazing approach, and it really allows access to the ventral part of the spine. You can get any disc herniation from T4 to L4, basically. You can get some L5-S1 herniations if they don't have a tall iliac crest, and you can get into the 5.1 foramen without a funky angle. You can get foraminal stenosis just about anywhere. And you can get even some lateral recess pathology, especially with more advanced degeneration or adjacent segment degeneration. And it actually takes a patient that you didn't like looking at adjacent segment degeneration before, and then being able to offer somebody an awake outpatient procedure that alleviates their claudicatory leg pain. They become a pleasure to take care of, because they'll typically have an opinion that they need a T10 to the sacrum extension, and you offer them a little 8mm stab wound, and that's a pretty easy sell. So what are the barriers to transforaminal approach? Well, I'm an orthopedic surgeon. I'm not a highfalutin neurosurgeon like Paul. I don't speak good. I don't read a lot, so I need pictures. I need to visualize something. So when I tried to convey the limitations to the transforaminal approach, I searched for a picture and I found one. If you've normally I tell people in the lecture, don't say anything if you've seen this picture, but I'm going to show you a picture. There's no Photoshop. There's no manipulation of the picture. It's just a picture, and we're going to throw it up here. So first time I looked at this, I think I stared at it for 20 or 25 minutes, and my brain melted. Like there's an asteroid, there's some trees in the background, there's a cliff, there's a grassy knoll. I could not figure out what the heck was going on with this. And after almost a half hour of staring at this thing, I clicked on the, explain the picture to me. And when I saw the proper perspective, I realized this is a great analogy for the transforaminal approach. So with the proper perspective, you see that this picture is just a picture of a rock in a pond, something you'd see walking down through any park or anybody's farm, and you instantly recognize all the structures. This is the best analogy for a transforaminal approach. You know the anatomy, you know what all the structures are, you know where they are, you know their relationships. It's just a perspective you're not used to looking at. You're not used to standing on the floor of the foramen and looking up at the traversing root or looking underneath the dura. That's like such a foreign concept from a posterior approach. But you know where everything is. You even know what the structures feel like. You know how much you can retract on them. So that was sort of opened my eyes to being able to convey the difficulties with the transforaminal approach.
And I hope that this is everyone's light bulb moment. I mean, that says it all. That one picture, that one little explanation just says it all.
And it's just like this. You look at this and you're like, what the hell is going on here? You got a dark hole, it's a cave, there's a road or something. Well, this is Wagner's arch. That's the pedicle supraarticular process. That's the disc. And if I just give you the perspective that you're used to, this is just a spine model in my office. You can see these are all structures you are familiar with. You know where everything is. You know where the traversing root is. It's deep in here. You know where the exiting root is. You can see the dorsal root ganglion. This is exactly what you see in real life. So here's a paper that discusses the efficacy of transforaminal endoscopic surgery out of Korea. It kind of shows things that you'd expect it to show. There's a shorter incision, less blood loss, shorter hospital stay. That's not necessarily translatable to things in the United States because, in Asia, they'll sometimes keep patients there till the wounds heal. They're still there less, but 3 days versus 7 days is sort of irrelevant to somebody who's doing outpatient surgery. I can tell you that you can discharge patients faster from an outpatient center, even doing this endoscopically, especially if you're not putting them under general anesthesia, because they get up and they walk right away and they can leave a little bit quicker. So lower hospital cost, shorter recovery time, lower complication rate, kind of all the stuff you'd expect from something that's less invasive. Lower visual analog scores for back and leg pain, which is what you'd also hope to see. But here's a part that all that other stuff could have some bias involved. This is a pretty objective finding. Post-op C-reactive protein and interleukin-6 were significantly higher in the microdisc versus TSIS group at 6, 12, 24, and 48 hours post-op. That's a pretty objective measure that this is a less invasive procedure and technique.
Yeah, and this is the first time, everyone equates small incision to being minimally invasive. Minimally invasive really means about how much tissue damage you're doing. So I would argue that an ACDF is a minimally invasive surgery because really basically you get the platysma muscle and that's it. And this is the first time, because I read this paper also, that this is the first time I actually saw biomarkers saying that this is less tissue damage.
Yeah, you got to really credit these guys for going to this length and sort of proving that this is less invasive. I'm going to go try to make this beeping stop here.
To delete all old messages, press all old messages deleted.
All right. Sorry about that.
No worries.
All right. So if you look through the literature, there's a number of review studies, literature reviews, 18 or so. Again, this is still level 2, level 3 evidence. It's not level 1 prospective randomized evidence. If you kind of summarize these review studies, these meta-analyses, what you see is endoscopic discectomy tends towards fewer wound issues and infections, even less than tubular surgery. So tubular surgery has fewer wound issues and infections than microdisc, and then endoscopic surgery has even fewer than the tubular surgery. There's less back pain, which makes sense if you're not disrupting the dynamic stabilizers and the normal soft tissue attachments. It should bother you less. You're not violating the facet joint as much. That should hurt less. There's a quicker return to activity, so much so that a lot of times patients just won't listen to me at all and go do whatever they want. And those actually are the ones that tend to do the best. So they've led me to decrease my restrictions on patients post-operatively. There's a shorter post-op stay. Some people will say, well, it doesn't matter if you're doing it as an outpatient. I can tell you that even in the outpatient center, if you can get somebody out quicker, there's cost savings to be had there. There's a slightly higher recurrence rate. That's borne out in the literature. Now, I think there's reasons for that. I kind of have an illustration here. I'm going to stop the screen sharing, just put my mug up here for a second, Paul.
Sure.
So I think one of the reasons for the higher recurrence rate is just the instrumentation. So if you look at this is a typical pituitary you'd use for like a microdisc or a TLIF, pretty good size. I think it's about a 3.5 millimeter. This is your typical endoscopic pituitary. So if you just look at the size of this, and you take into account the fact that you are really close to the pathology and everything's magnified, you can take out a small disc fragment and really go, oh my God, I took out half the disc. And when it pulls out, it looks pretty wimpy. So one of the things that I did when I started doing this, I was really aggressive about trying to go into the disc space, because no matter how aggressive you're being, it's less aggressive than you think you are. One bite with this thing is like 20 with this guy. So that's pretty impressive difference.
Well, and not only that, going back to one of the other points in the slide is that the earlier increased activity. I think that also leads to more chance of having a recurrence, because people aren't restricted by their pain, so they forget and they go out and do things they probably shouldn't be doing. So I had one person who decided to change out a sliding glass door on their deck. Obviously that person had another surgery.
At the same time, if you have a recurrence early, if you go back in with the endoscope,
It's nothing.
It's still less invasive than if you had the microdisc the first time. So you still haven't violated the joint. There's typically a path there. There's not very much in the way of scar tissue. Basically go in, pluck out the second. In some ways, the recurrence is easier to do because the epidural veins are slightly tamponaded for you already. So that's sort of the evidence if you look at the literature. Let's see here. Some people are still going to be thinking, well, I'm going to stick with my microdisc. I don't have level 1 prospective randomized evidence. I shouldn't make a decision based on that because I am an evidence-based medicine guy. Well, the reality is there's no good evidence that the microdisc is significantly better than open discectomy in the long term, yet microdiscectomy is the gold standard treatment. So, I mean, why is that? Well, it's just sort of intuitively obvious if you look at a microdisc and you look at an old-fashioned laminectomy and discectomy with a 6-inch incision, yeah, sign me up for the microdisc, especially with the use of a microscope where your visualization is good. So, now that we have 4K and 5K cameras and fantastic optics, the visualization is just as good, if not better, with the endoscope, because you can look around corners. So what's the argument for tubular discectomy? I transitioned from microdisc to tubular discectomies a long time ago. Well, why would you do that? There's not evidence that tubular disc is better, and if anything, it has a higher recurrence rate. There are fewer wound problems in microdisc because you don't have the edge of the retractor loading the skin. But there's a slightly higher recurrence rate. I think this is one of the tube paradoxes where people tend to want to use a bigger tube because it's easier to operate, but it doesn't fit the bony window as much between the facet and the spinous process. So they end up elevating the tube off the spine, taking away more soft tissue, actually doing a more invasive surgery. But the real reason you use the tube for the discectomy is because it makes you a better tube surgeon. So you have one platform you can apply to all pathologies. And then that makes you better at doing, unilateral laminotomy, bilateral decompressions. It makes you better at doing minimally invasive T-lifts or, typical bread and butter spine surgeries. So, you're going to do a lot more discectomies. Frankly, I think a tubular disc is harder to do than a tubular decompression or T-lift. So you need to have the same platform. You can't be going to the OR and going, today I'm going to use the tube and the microscope, tomorrow I'm going to use the endoscope, and the next day I'm going to do it open with loops, and it's just going to confuse everybody. So the same logic can be applied to endoscopic discectomy. Once you get comfortable removing the disc herniations with the endoscope, then you're going to start to see more structures and realize, wow, I can reach, say, the lateral recess through the foramen on occasion. I can access lateral recess stenosis. So, I could do this decompression without having to remove a lot of soft tissue or remove a lot of bone or destabilize the joint. And, no, wait, I can reach across the other side of the canal. So we're going to do a little thought experiment. The reason I put Einstein up here is,
I was wondering where you got that picture of me.
That's right. You've got that COVID hair. So, Einstein reasoned out the theory of relativity with no bench work. It was complete thought experiments. That's just amazing to me. So don't poo-poo this. It's fairly powerful. So we're going to do is a thought experiment. And what I want to do is imagine that you have a herniation that needs an operation. Now, the problem I usually have when I present this thought experiment to a room full of spine surgeons, I say, hey, you've got a disc herniation. What surgery do you want to do? Half the room says, I don't want surgery. So I think that's a pretty poor commentary on our specialty when you've got half the room doing surgeries that they wouldn't want to have done on themselves. I mean, that bothers me a lot. So we're going to make this where you've got a foot drop, you've got horrible pain, you've tried injections, therapy, medications, inversion tables, chiropractic, whatever you want to think of. You've tried it all. It's not working. You got a progressive neurologic deficit. You're in pain and you can't work. So it's time to have surgery. I'm going to suggest that your presupposition should be that the long-term results are the same no matter which surgery you have. So your options are going to be an open discectomy, a microdiscectomy, a tubular discectomy, or an endoscopic discectomy. But long-term results, 5 and 10-year results, are exactly the same for all of them. So that's your presupposition. So the question then is, you're miserable, you have to have surgery. Which surgery do you want to have? So that's the thought experiment. So we play a little Jeopardy music here.
Oh, I wish I had some. Da-na-na-na-na-na-na. I think I'm going to go with E equals MC squared.
So typically when I give this talk, about half to 3/4 of the room will choose the endoscopic discectomy because I think that's the only logical choice at this point, because I told you the long-term results are the same. You had to have surgery. Why wouldn't you pick the thing that's the least invasive with the fastest recovery and the least need for narcotic? It's the only logical choice. That evidence is overwhelming for the endoscope.
Right. If
you pick microdisc, it just means that your bias is such that you really don't think you can do the effective surgery with the endoscope. So, minimally invasive surgery it can't compromise on the fundamental objective of the operation. The decompression and stabilization that you want to achieve still has to be achieved. not getting those goals done, but having a smaller incision is not acceptable. So, comparing a poorly done surgery, whether it's done open or minimally invasively, is to a well done surgery. The poorly done surgery is always going to lose. So the fundamental question really is, can you achieve the goals of the operation through the endoscope? And really, Paul and I are here to tell you that you can. So here's the Gartner hype cycle. Again, kind of see if anybody revised their answers. I think we're at the slope of enlightenment here, on the lower end of it. I think I've shown that we've passed the technology trigger a long time ago. There was a period a few years back where there were proponents of endoscopic surgery that were saying, hey, you could treat anything with this. You can make back pain go away. You can treat degenerative discs and not have to do fusions. And we can make all sorts of pain go away. It's almost as if it were a magic wand. And the endoscope is not a magic wand. It's just a tool. So I think that led us to the trough of disillusionment. And now that we've refined the optics, refined the instruments, we're here at the slope of enlightenment, because now we're able to do decompressions as an outpatient. We're able to place interbody devices and do it in a less evasive manner, but not compromise the fundamental goals of the procedure. And I think that the time we get to the plateau of productivity is going to be when we're able to deploy through an endoscopic approach an interbody device that is basically the size of an A-lift graft or implant through a T-lift or PLIF approach. And I think that's going to get it over the hump and make this mainstream.
I think you're completely right. And, going back to that slide, the where you get into the productivity stage, I mean, all of Asia is already in that plateau of productivity. I mean, they're doing, I know that in one province alone, they're doing 25,000 transforaminal discectomies a year. I mean, this is the way it's done in Asia. And, anatomy is the same no matter what. And if it's working over there and they're having great results, there's no reason why it wouldn't work over here. It's just getting back to how we're trained and what we're comfortable doing and being able to transition to do something different than what you already do. And I think that's why we're in the slope of enlightenment. I couldn't agree with you more.
Yeah, it's interesting. In Asia, this is a separate service line.
Yes.
Like the endoscopic guys, that's what they do. They do endoscopic spine surgery. And, that appeals to me as an orthopod because, I used to play sports years ago, and I had lots of friends that had orthopedic surgery, got back to playing sports. And I always thought sort of sports was sexy, outpatient, arthroscope. Then I decided to go into spine like an idiot. And then realized, oh my God, this is barbaric. What I should put up here is a picture of an open spine surgery and the picture of an endoscopic approach incision. And, you just take somebody that doesn't have any symptoms and say, which would you rather have? And it's like, well, that's a no-brainer. But I still like the idea of being able to use an endoscope and do outpatient cases. And so maybe I'm just trying to recreate my love of sports when I was younger. So we'll go through some case examples. Here's a 68-year-old female with left L3 radiculopathy due to a foraminal herniation of L3-4. Severe claudicatory pain and weakness that's now constant, preventing her from walking. She presents to clinic in a wheelchair because any standing and walking causes pain. Due to progressive weakness and inability to walk, she undergoes a left L3 awake transforaminal endoscopic discectomy. So here's her pre-op MRI. You can see here in the foramen, she's got a herniation at L3-4 in the foramen, so it's tickling the traversing 4 root. It's hitting the exiting 3 root. It's not really far lateral. It's not really posterolateral. It's right between the pedicles. And this is sort of a miserable place to do a traditional approach. You can't really get here safely through the canal. If you do a traditional McCullough retractor laminotomy, you can't really reach out all the way unless you cut across the pars and destabilize the spine. And if you do even a tubular far lateral approach, you end up removing a fair amount of the joint and have to take a really oblique approach, which makes the wound super deep. If you get that little bleeder in there, it's really tough to chase after and make it go away. And this is like falling off a log with an endoscope. You basically place the endoscope into the Cambens triangle, land on the disc herniation, and pluck it out. And you do it without having to remove any bone or violate the joint. So this is the post-op MRI at 6 weeks. When I first started doing these, we did a few MRIs on patients post-operatively to make sure that I was doing what I thought I was doing. And, I think this looks pretty good. The herniation's gone. The foramens look symmetric. There's no significant bony resection. But what's most impressive to me is if you look at the paraspinous muscles and the soft tissue surrounding this, if I told you this person had surgery on their spine 6 weeks ago at this level, I don't think you would believe me. Because really there's, you look at a microdisc 6 weeks post-op on an MRI, it looks like a grenade went off. There's edema and muscle atrophy, and this looks fairly normal. Here's the incision. There's her pain sheet from 10 out of 10 to 0 out of 10. Here's a 32-year-old law enforcement officer with new onset right foot drop, has an L5S1 spondylolytic spondylolisthesis without significant foraminal stenosis. He's had intermittent back pain, nothing terrible, typically treats it with some Advil, has been able to go through the academy and perform as a law enforcement officer until he develops this new foot drop due to a cephalad extruded herniated disc at L4-5. So here's his MRI. You can see the herniation at 4-5. He's got a spondylolytic spondylolisthesis at L5S1, but it's not giving him long-term problems. He's got an acute problem, and that's the foot drop. So this is also a case that when I present to a room full of surgeons, oftentimes half the room wants to do a 2-level fusion on this guy. And I tried to set this up where he's got an acute foot drop from a herniation. If you just address the herniation, you can leave the spondylolisthesis alone. And, I think that's one of the issues with spine surgery is operating on the MRI rather than the patient. So, if you can alleviate his herniation and improve his foot drop, you should be able to get a pretty good result with this. So
that's an excellent point, Ray, because you're right. You see this and you're like, well, disc space collapse, big herniation, spondylolisthesis, 2-level fusion, and it doesn't need to be.
And I would suggest that if you took this law enforcement officer and you did a 2-level fusion on him,
he's done.
Yeah, and you're going to be back fusing this one in a period of time. Now, if you're looking for an annuity, that may be the way to go, but that's not what I would want done if I were the patient. So here's his post-op MRI. We did this from a transforaminal approach. Again, no soft tissue damage, no inflammation, paraspinous edema. Herniation's gone. He's got a little bit of occasional back pain, but he had that before. But we're able to approach this through the foramen, not disrupt any of the posterior musculature, not risk destabilizing this L5S1 level. L5S1 level is pristine and untouched. It's like it hasn't had any surgery. Because it hasn't, we're able to go through the foramen and access this herniation. And, that's just an incredibly powerful tool. Here's a 42-year-old male executive with severe bilateral leg pain, actually left more than right. He's got weakness in both legs. He's got claudication and nerve tension signs. So if he stands and walks, it hurts, but if he straightens his leg out, it hurts. So he can't drive. He's not sleeping. He's pretty miserable. His father had a discectomy 25 years ago, spent 3 days in the hospital, and he feel like he didn't fully recover for 6 months. He kept telling his son, do not have surgery. It's terrible. Let it get better on its own. So after 6 months of trying to do this and him getting progressively worse, he finally said, look, I need to get something done. I don't care what it takes to recover. I can't take this anymore. And anybody who hasn't slept, that string's pretty short. So MRI has a massive contained central herniation at 4-5. This is his pain sheet. So he marks left leg pain, but he does say he's got some right leg pain. It says that the left leg pain's what brought him in. Here's his herniation. Now, that's a whopper. Basically he's got a mild cauda-equina syndrome. He's got bilateral L5 radiculopathies with a large central herniation. So, I'm sure there are people that are saying, well, then this thing needs a total laminectomy and a wide decompression. So if you try to do this from a traditional posterior approach, there's a fair chance that you're going to end up doing bilateral laminotomies and removing portions of the facet joints on both sides to ensure that you've got it decompressed and able to reach everything.
Not to mention a fair chance of getting a dural tear there.
Yes, but this thing's stretched out and flattened out like crazy. So mobilizing you're basically going to have to reach underneath the root after removing a significant portion of the facet, reach under the root and grab disc and nothing else to get it loosened up, and then mobilize the root. So this is a miserable surgery to do. It's a miserable surgery to have from that approach. Plus you damage all this tissue. Well, with a transforaminal approach, take a little flatter approach here to the frame, and luckily he has nice big foramen. I really didn't even have to ream, and I was able to reach in here and go to the contralateral side of the spine. So here's actually the intra-op pictures of the fluoro shots. You can see reaching across the midline, advancement of the cannula almost to the midline. Here's the disc material removed. Had surgery on a Friday. He was discharged with naproxen, no narcotics. So we don't give discectomies narcotics anymore. They don't need it. The approach is pain is covered with just an anti-inflammatory. He drives on Sunday. He returns to work on Monday. He basically sits at a desk. So drives to work Monday, goes back. And his father came back and was like, where the hell was this 10, 15 years ago when I had surgery? So that's his pain sheet. This is actually his 1 year pain sheet. His 2 year pain sheet looks the same. And this is actually his surgery. So this is the herniation on the left. You can see he had a pretty big piece. That's very satisfying when you have to remove the scope to remove the herniation because it's too big to fit through the cannula. And you can see the hole in the annulus. And at this point, he actually is telling me my left leg pain's better, but I'm still having some right buttock and right thigh pain. So I advance the cannula a little bit. I poke around. If you look here, you can see the epidural veins in the midline. So this is actually a disc fragment on the contralateral side of the spine on the right side that when I poked on it, it reproduced his pain. So I reached in, grabbed the piece, and there's a big fragment in there. And actually, it takes sort of 2 video shots to show the full fragment because this is actually when it's sort of moved out towards the foramen and I'm finishing pulling it out.
When you bring up an important point and advantage of the awake endoscopic surgery is that the patient's directing you to do more because, hey, doc, my right leg's bothering me, and you know that you need to go in and get more.
Yes, I had a number of patients that, I'm looking at the nerve and I'm thinking, it looks pretty good. It's pulsating. It's free. I can probe around. It looks all right. And they're like, no, it still hurts. And you'll poke around, just in the subannular space and you'll find a tender spot. It'll reproduce some of their pain. You'll reach in there and grab another piece out and they'll say, wow, that was it. My pain's gone now. And then oftentimes they'll just pass out and start snoring because they've been getting sedation to make them comfortable while you're working in there. And then it's too much sedation when the negative stimulus is gone. So this is a picture intra-op. You can see here this video screen at the head of the bed, and Calissa, our nurse anesthetist who volunteered to do this awake stuff, is up there. She's seen enough of these cases where she's talking to the patient. Patient's got his head turned to the left, looking at the video, and she's talking them through going, hey, there's your disc herniation, there's your nerve. Sorry, I didn't have the audio working on this, but Paige here squeals like a little girl at this piece because it pops out. So, if Calissa can watch this surgery and explain to the patient where their nerve is, where their pedicle is, where the herniation is, here you're going to get relief here in just a second. I'm pretty sure most spine surgeons can do this.
Yes.
Here's a 34-year-old zookeeper, 6 months of progressive worsening right S1 radiculopathy, could tolerate pain at work, got great core strength, very compliant with the core program. She gets temporary relief with the injections, works for a few weeks. She has a 5-1 herniation with a shallow pelvis. So here's her pain and S1 radiculopathy. I really like the pain sheets. I think these things are invaluable. Here's her herniation. So this is a dealer's choice, right? She's got a nice interlaminar window. You could go from an interlaminar approach. You could go from a transforaminal approach. She wanted to do this awake. At this time, I was doing my interlaminars under general and my transforaminals awake. So she wanted to try to avoid the general anesthesia. So I approached this transforaminally and were able to get the herniation because she had a nice shallow pelvis. The iliac crest wasn't in the way, and she had a decent sized foraminal window. So here's her post-op pain. She basically went back to work as a zookeeper 2 weeks post-op. She never got narcotics. This is her 1 year follow-up. She is an elephant feeder, so she carries like buckets of feed up a ladder to feed the elephants, which is to go back and do that 2 weeks after a discectomy, I think is um, pretty
Now, are you doing your interlaminar surgeries awake now?
well. So this is one of the things that unanticipated benefit of quarantine and coronavirus. Um, we've had some patients that needed an acute discectomy uh, with an interlaminar approach, and I was able to talk to anesthesia and say, look, we don't want to intubate these people because we don't want to spread aerosolized lung products all over the room. Let's do this under conscious sedation. I've actually done a unilateral laminotomy, bilateral decompression with an epidural and conscious sedation, and I'm excited about that because avoiding the general anesthesia, I think, is a major benefit to this. Patients wake up faster. They don't get the urinary retention. They don't get the fog, especially elderly patients. You can take an elderly patient and they can be really, really confused after general anesthesia and be delirious. And that's dangerous, especially when you send them home. So here's a 45-year-old male with 6 months of L4 radiculopathy on the left and quad weakness. He had 2.5 weeks of relief with transforaminal injections. He couldn't tolerate therapy because every time he tried to do physical therapy, it would provoke his pain. He heard about the endoscopic approach, came to me and said, hey, doc, I don't know if I'm a candidate for this, but I heard about this procedure. I want it done. And I said, oh, that's not how this works. You actually need to be a candidate for it. But it turns out he was. So here's his pain sheet, back, left leg. It's L4 distribution, goes down past the knee into the shin. He's got an L3-4 disc herniation. He's got a fairly degenerative L4-5 disc, but he's never really had any back pain. This is sort of a new acute problem for him. So here's his video, intraoperative video. You can see the traversing root and the herniation just underneath. I'm going in with the Jerry Springer there and grabbing the fragment out. Now, as I grab that fragment and I pull it out, he literally let out a, that was it. And then he passed out. He started snoring. It was the coolest thing. And he basically said, you got the spot. So
you've got the pointer on the mouse. Could you just show the viewers what the traversing root is? There you go.
Here's a traversing root. Here's the herniation. You see the fluffy white stuff here. And just reaching underneath the traversing root and grabbing the fragment, pulling it out. And he went, and he started snoring. That's all I heard after that. So here's his pain sheet post-op. He had surgery, I think it was on a Wednesday, and he had a business meeting he had to go to on a Monday. So he got on a plane, carried his carry-on bag. He promised me not to make it very heavy and went to a business meeting out of town. That patient, by the way, if you go to my LinkedIn page, there's a video testimonial of the patient that had an awake transforaminal endoscopic disc. That was him. So it's a really good video to watch because he is interviewed in the post-op recovery area where he still kind of had some vague memories of the procedure. And he has a very good description of what it's like to have an awake endoscopic approach. So here's a 29-year-old female dean of students at a private high school, left L5, S1 herniation with S1 radiculopathy. She had pain, didn't tolerate conservative measures. Temporary relief with an injection, sort of the same story. Here's her intra-op view of the interlaminar discectomy. You can see that unlike, say, a tubular or microdisc where you tend to go more parallel to the disc, here I'm following more the contour of the trailing lamina of 5. And the reason for this is you want to get through this interlaminar window basically with a fenestration in the ligamentum and not have to violate the facet joint or remove any significant amount of bone. So this is a sort of little video of her interlaminar approach. This is the trailing edge of the L5 lamina I'm cleaning off, and then advance the cannula. This was early on, so now I go kind of straight down to the ligamentum. This is the ligamentum flavum. You can see the superficial ligaments, bright and white. Um, this is the punch to open up the ligament. And as you get to the deep layer, you see it gets very thin and white. And then you pop through and hit it with the punch, and you've opened up the epidural space where you see the epidural fat. This is where the advantage of the fluid comes in, because it actually pushes the dura out of the way and dissects between the ligamentum flavum and the dura, so you can make that punch hole safely. This is the fenestration of the ligament opened up, removing some of the epidural fat so you can see the neural structures, and you can see the thecal sac, the S1 root, and basically the axilla. So there's the lateral edge of the S1 root. Sometimes you have to take more ligament. There are times you may even have to take a little bit of the superior articular process of S1 to get lateral, but on this patient, she had a nice wide interlaminar space. I was able to advance the cannula and place the tang of the cannula down lateral to the traversing S1 root into the floor of the canal. So the cannula itself works like a retractor.
So right. So the open bevel is towards the traversing root and the thecal sac.
Yes.
And you're about to rotate it.
But it's stuck. It doesn't want to go. So I go down and I release some of the adhesions. So they're trollard ligaments. So the S1 root is attached to the floor of the canal. You can see me release one of these dural attachments, and you can actually see the disc bulge up. Mm-hmm. So there are times when you've got pressure on the S1 root at the takeoff of the thecal sac, and the herniation may not look as impressive as you would expect based on symptoms, but it's because the S1 root is actually tethered to the floor of the canal. So the herniation is pushing up, the root's tethered, and it's sort of stuck. And you can see now that we mobilized the root and pushed it off the disc, this thing pushes up into the canal. And this first bit is a little piece. This is sort of the tip of the iceberg here. You go, okay, well, that's not a bad piece. Well, let's look around in here. You reach in, and here's the gift that keeps on giving.
I mean, I've had the experience as well where you rotate that tubular retractor to retract the nerve out of the way, and the disc just delivers itself up the tube.
Right. Yeah, it births itself. So here's after the decompression is complete, you can see the traversing S1 root. It's nice and round. It's pulsating the heartbeat. You can see there's space underneath it. It's no longer flattened and stretched. You can go directly into the axilla if you want and probe it around. For this, I just reach in with a probe and feel for it. But for an axillary herniation, you may have to approach it through the axilla. And you can do that safely with the endoscope, because your tube will protect your neural elements. So here's a typical incision at a year post-op. Here's another one. You can see that's my bad cuticle, my index finger. So this is sort of what's possible with this. I showed a bunch of lumbar discectomies. That there are things that I think most people can do even starting out. Here's a 38-year-old female with T7 radicular pain, getting worse despite conservative management. She's got dysesthesias around her chest without any long track signs. She's got a soft disc herniation and no calcification on her CT. I'm her third opinion. Here's her herniation. You can see I'm sort of already planning out on the MRI where my corridor is, how to get to it, if I can get to it. So first surgeon said, live with the pain. It's not worth having this operated on. Second surgeon said, I'll do a thoracotomy and partial corpectomy, discectomy, and anterior fusion if it gets any worse. So I did a transforaminal epidural on her, and she got 3 weeks of just profound relief, which suggests that, one, I can find the level, which is half the problem in the thoracic spine. It's just counting up and down from the ribs to locate your level. And two, it shows that, yeah, this is real. This is actually her symptoms. So I offered her a wake transforaminal endoscopic discectomy, understanding that if she didn't get relief, then potentially you're looking at a thoracotomy. Well, she went home pain-free 2 hours after surgery and returned to work as a prison guard 2 weeks after surgery, which you compare that to dropping a long chest tube, being in an ICU for a couple of days. That's like a major improvement.
I mean, there is no comparison.
No, this is a small outpatient procedure. So she was so happy, she let me treat her iatrogenic spondy that I didn't operate on the first time with an outpatient TLIF. So here's actually the fluoro view reaching across to the midline. And then this is the undersurface of the thoracic cord where I drilled away portions of the end plate to create a cavity to push the herniation down away from the cord and pluck it out and decompress everything. So I think that's pretty much it.
All right. Well, that's absolutely fantastic, Ray. Um, just what you're able to do and the patients we're able to treat with this technique sort of answers the question why bother. We bother because it's for the patients. And we're able to offer them an alternative to a very large operation with very low risk and a potentially great benefit.
Yeah, really, the reason I got into this was I got introspective a few years back, and I thought to myself, boy, if I had a herniation, how would I want it operated on? And looking at the evidence, this was the answer. So I was like, well, I can't conscionably do surgery on somebody that I wouldn't want to have done myself. So, um, kind of ripped the band-aid out and forced myself to jump in head first on this.
Well, I thank you again for your time and your insight. And hopefully we'll get together again and do another discussion, talk about maybe we'll do something with thoracic discectomies, or I know you're doing a lot of cervical. Perhaps another time you'll be willing to come back and tell us how you treat some cervical disc problems.
Yeah, just quickly on that, that's like one of my new favorite operations. You've got no hoarseness, no dysphagia. It's a tiny incision. They're basically not activity limited. There's no implant costs. You don't have to wait for bone to heal. It really is. If you look at the data from the literature, the recurrence rate is incredibly low. It's probably the safest way to approach a cervical disc herniation with a radiculopathy, as long as you don't have central cord compression. So
Again, making the case that, again, this is the platform that can still lead to other things. So thank you very much. And that ends our discussion. Thank you very much.
thanks, Paul.